Hello everyone, myself Tulsi Patel. So today we will learn about physical examination of the ear, and I'm working as nursing tutor at Knowledge Institute of Nursing. So this is the anatomy of the human ear. So you can see this, the internal bone, the malleus, incus and stapes, the semicircular canal, the cochlea, the facial nerve, the internal auditory canal, the audiovestibular nerve, then eustachian tube, then carotid artery, jugular vein, facial nerve, then this one is the mastoid process, and here is the ear canal. And this one is the temporal lobe, which is closely attached to the ear. Here is the temporalis fossa. So next we will see. So first we will move with the inspection. So inspect the auricle of the ear for the parallelism, size, position, and appearance and skin color. Then next is the palpation. So palpate the auricle and the mastoid process for the firmness of the cartilage of the auricles and tenderness when manipulating the auricle and the mastoid process. And inspect the auditory meatus or the ear canal for the color, presence of sediment, discharge, and foreign body. Sometimes many of the kids and children have this foreign body accident we have seen in the hospitals, like, and we have to even observe for the wax, we usually remove it, so we have to inspect our ear for that. And the most important thing, how you will get to visualize the ear. So in adult, pull the pinna upward and backward to straighten the ear canal, while for the children, pull the pinna downward and backward to straighten the ear canal. You must have to remember these two techniques. Then perform the otoscopic examination of tympanic membrane, noting the color and landmark. Sometimes many of are suffering with, many are going for tympanoplasty because their tympanic membrane are getting perforated due to many are using the upins and all for clearing the ear canals, which is totally not a good practice. And you should not use your earbuds in the internal ear. You can use it for the external ear, but not in the internal ear. You must have to remember these things, and you have to educate this to your patients too. Then here is the structure of the external ear. So you can see here is this area called helix, and this one is the antihelical fold, and this one is the antihelix. Then here is the external auditory canal, then the lobule, then tragus and antitragus, and para-auricular skin tag and para-auricular skin pit. So you can easily identify this part by just visualizing the ear. Then what are the normal findings? So the earlobes are bean-shaped, parallel and symmetrical. The upper connection of the earlobe is parallel with the outer canthus of the eye. Sometimes in many patients we are seeing the low set of ear. For example, in Down syndrome, if the patient is suffering with Down syndrome, person will have low set of ear. So you can notify this genetic abnormality by inspecting the ear, just by inspecting the ear, and you should note it down. The skin is same in color as the complexion. Then no lesion noted on inspection. The auricles are has a firm cartilage on palpation. The pinna recoils when folded. There is no pain or tenderness on the palpation of the auricle and mastoid process. If the patient is feeling pain, then the patient is suffering with otitis media or external or any disorder, then myringeotomy, etc. So the ear canal has normally some ceremony of inspection, no discharge or lesions noted at the ear canal. So on otoscopic examination, the tympanic membrane appears flat, translucent, and pearly gray in color. If it is pearly red or pinkish in color, means the patient is having infection of tympanic membrane. So next is vestibulocochlear nerve, cranial nerve 7 assessment. So examination of cranial nerve involves testing, cranial nerve 8. So that it involves testing for hearing acuity and balance. So we will see first the hearing acuity test. There are many tests. So the first one is voice test. So it used to determine whether hearing loss has occurred or not. So one ear is tested at the time. The ear not being tested is uploaded by the client. So you have to cover the ear which you are not going to test first. So the nurse stands 1 or 2 feet, that means 30 to 60 centimeters from the client. Cover his or her mouth so that the client cannot read the lips. Exhale fully and softly whisper two-syllable word in the direction of the unoccluded ear. The client point a finger up during the test. When the nurse voice is heard, a ticking watch may also be used to test hearing activity. Then next is failure to hear the sound could indicate possible fluid collection and consolidation requiring further assessment. This is not the final diagnostic test, but this test can suggest us to do the further assessment. So next one is the watcher test. Ask the client to close the eyes. Place a mechanical watch 1 to 2 inches away to the client's ear. Ask the client if he or she hears anything. So if the client say yes, the examiner should validate by asking at what are you hearing and at what side. So repeat the procedure on the other ear too. Normally the client can identify the sound and at what side it was heard. If client cannot hear it, you should notify the physician immediately. Then the next are tuning fork test. For this, you will need the tuning fork in your instrument tray. So there are many tuning fork tests, but we will study about Weber's test and Renan's test. So first we will see the Weber's test. You can see in figure, it is used to assess the conductive hearing loss. And what is the technique of that? So the place a vibrating tuning fork in the midline of the person's skull and ask if he can hear the sound same in the both the ears or better in one ear. So why we are putting this tuning fork in the midline of person's skull? So at that area there are sutures. All have studied the anatomy and physiology. So skull have bones which is connected with the suture line, right? So we are putting the tuning fork on sutures which can transmit the vibration to the ear. So the result is the person should hear the tone produced by bone conduction equally in both ears. It is the positive test result. So if patient is not hearing the tone produced by that conduction, means that is abnormal. Patient is suffering with some part of deafness. Then you can see the example. A patient reports a recent decrease of hearing in the right ear. The Weber refers to the right. This suggests a conductive hearing loss on the right side. So then we will see the next example. Like a patient report a recent decrease of hearing in the right ear. The Weber refers to the left. This suggests a sensory neural hearing loss on the right. So you will study this in detail by practicing it. Okay, so you must have to do the practice. We will study it in labs. Then the next is Renan's test. This is the test to compare the air conduction and the bone conduction sound. So what is the technique of that? So place the stem of the vibrating tuning fork on the person's mastoid process. Already we have seen the mastoid process where it is located, and ask him or her to signal when the sound disappears. Note the time in seconds. Invert the tuning fork so the vibrating end is near the ear. Canal, he should hear the sound, not the time in seconds. So usually what is the result? The air conduction and bone conduction. So air conduction should be more than bone conduction, means 2:1 ratio. But if it is opposite, means there is something is abnormal. The patient is suffering. Okay. So what is the interpretation? So if the sound cannot be heard by air conduction or doesn't continue to be heard for at least as long as it was heard by bone conduction, there is conductive hearing loss in the ear being tested. So next we will see the vestibular assessment. The first test is test for falling. It is also called the Romberg test. The examiner asks the client to stand with the feet together, arms hanging loosely at the side and eyes closed. The client normally erect with only slight swaying. A significant sway is the positive Romberg sign. Means person cannot balance his or her body, and so the person's vestibular nerve is not working properly. So this is how you can elicit this test for falling in your clinicals. So next one is test for past positioning. The client sits in the front of the examiner. The client closes the eyes and extends the arm in the front, pointing both index finger at the examiner. So the examiner will hold and touch his or her own extended index finger under the client's extended index finger to give the client a point of reference. So the client is instructed to raise both arms and then lower them, attempting to return the examiner extended index finger. So the normal test response is that the client can easily return to the point of reference which has been provided by the examiner. The client with the vestibular function problem lacks a normal sense of position and cannot return to the extended finger to the point of reference. Instead, the finger deviates to the right or left of the reference point. So how you can elicit? You will understand it by seeing in the figure. So you can understand this. This is also called the finger to finger and finger to nose test. You will also study this same technique in the neurological examination. Next, we will see the gaze nystagmus evaluation. So the client eye are examined as the client looks straight ahead, 30 degrees to each side, upward and downward. Any spontaneous nystagmus and involuntary rhythmic rapid twitching of the eyeballs represent a problem with the vestibular system. So this is how you can do assessment of gaze nystagmus evaluation. Okay. So I hope you have understood the examination of ear and you can perform it very well. Okay. Thank you so much for